Greetings and welcome back, participants, to this session of the Africa Calls Cytopathology Lecture Series for 2023-24. I am Dr. Leslie Lomo. I'm here with my co-host, Dr. Alarise Lowe, as part of the present coordinator for the series, here to moderate today's session. Just a little bit of housekeeping. Just a quick reminder for questions, please use the Q&A function. Dr. Lowe and I will be monitoring that, and we will run through the questions at the end of the webinar. And lastly, there will be a series of questions that will pop up when the webinar ends. Please stay on to review and answer those questions so that we receive feedback so that we may be able to better tailor the series for your needs. Okay, so for today, we are very, very pleased to welcome Dr. Lester Layfield as our guest speaker, a very highly distinguished academician. He may not need introduction to many of you, but just to highlight, in his very distinguished career with numerous accomplishments and accolades, his most recent highlights include directorships at the Duke University Medical Center and director of the Anatomic and Molecular Diagnostics Laboratory at actually my institution, ARUP Laboratories. I did not get a chance to overlap with him because he then moved to serve as chair for the Department of Pathology and Anatomical Sciences at the University of Missouri School of Medicine until 2018. He is currently there as a professor of pathology and continues to contribute significantly to the cytopathology community with over 400 publications, numerous book chapters, books, and presentations at national and international meetings, and remains a highly active member of our national societies, American Society of Cytopathology and the Papa-Nicolau Society. And we are very, very fortunate to have him present to us an overview and introduction to the new WHO reporting system for lung cytopathology. And with that, I will turn it over to Dr. Layfield.
Well, thank you very much. We'll take the next slide, if we could. And what I'm going to do is discuss and introduce the new WHO reporting system for lung cytopathology. This is actually based on a predecessor, the Papa-Nicolau Society system for reporting lung cytopathology. There are some changes, but the two systems are substantially the same with modifications of definitions of one or two categories. Next slide, please. Next slide. And I have nothing to disclose. Next slide. Well, why pulmonary guidelines? I think this is a very important question. Guidelines are a lot of work to create, and they are somewhat of an effort to follow. I think they came into existence because terms that were used in the 70s and 80s actually had variable meanings among cytopathologists and different institutions. For a long while, the term atypia in some institutions meant that this was just reactive atypia. It was clearly benign. The cells were just not absolutely normal looking. Whereas in other institutions, titles like slight cellular atypia were used, which really doesn't have much of a meaning any longer. And then other people use the atypia as part of atypical, suspicious for malignancy, when they really meant that this lesion was very, very suspicious for a carcinoma, and they really had sort of excluded anything benign, but didn't quite have enough features for a definitive diagnosis of malignancy. So the guidelines were introduced first for cervical cytology, then thyroid, and then more recently for pancreaticobiliary and respiratory. What they do is they give us a common nomenclature, so everybody is speaking sort of the same language. The terms have well-defined meanings that can be used uniformly. So this enhances communication between cytopathologists among themselves, and most importantly, with clinicians. The standardized terminology is important for both intra and interinstitutional use. So somebody using the term suspicious for malignancy has the same meaning and risk of malignancy in Los Angeles as it does in Paris, France, and that's very, very important. And also, these guidelines allow assessment of risk of malignancy that really communicates a lot of information to the clinician on how to manage his or her patient, and also gives a patient some idea as to how likely they have a cancer. Next slide, please. Now, the WHO categories for pulmonary cytology are listed here. There are 5 of them. The first, insufficient, inadequate, and non-diagnostic, replaces the non-diagnostic category used in the Papa-Nicolau Society. The meaning is substantially the same. The PAP Society picked non-diagnostic because it did not indicate that there had been some problem with obtaining the specimen. It is sort of a no-fault type category designation, but the WHO felt that there were other terms that might give more information, and hence insufficient, inadequate, and non-diagnostic. Benign is really a fairly simple category. It indicates that the material one sees that, in the opinion of the cytologist, is benign and has no malignancy risk, but we'll see they actually do as we get a little bit further on. The two categories, atypical and suspicious for malignancy, are very important indeterminate categories that allow us to break up a spectrum of cytomorphologic changes that runs from clearly benign with effectively no risk of malignancy to clearly malignant, where malignancy risk should be 100%. Now, in these two intermediate categories, they are useful for dividing up estimated risks of malignancy in that spectrum that does not have clear cut points that are quantitative. Next slide, please. This just shows that risk of malignancy is dependent on technique as well as category. We're all familiar with a risk of malignancy assigned by category that increases from negative or benign to atypical, suspicious, and malignancy. But depending on how you obtain the specimen, that will also impact the malignancy risk for any diagnostic category. And that's just something that I think for consultation purposes with a clinician is important to remember. Next slide, please. Now let's look at the first category, insufficient, inadequate, or non-diagnostic. These, what are assigned to this category, are specimens that provide no useful diagnostic information about the nodule, cyst, or mass that's identified on imaging studies. And any degree of cellular atypia, even one cell, precludes a non-diagnostic category. If you have any atypical cells, it will go into some other category. It may be benign, it may be atypical or suspicious for malignancy, but you cannot use the non-diagnostic category. Next slide, please. Now, what are the cytologic criteria? And these get a little complicated, and they've shifted from the Papa-Nicolau Society criteria to ones used by the WHO. But if you have preparation artifact that precludes evaluation of cellular elements, like massive crushing of the specimen when you smear it, or placing it in water instead of fixative, all of those will give artifacts that you just can't evaluate the cellular elements. They're non-diagnostic. Similarly, when you have excessive blood or mucus, those can obscure the cellular elements. You just can't analyze them. Again, goes in the non-diagnostic category. Gets a little more difficult from there because there is controversy for what you do with a specimen that contains only normal cellular elements, let's say absolutely benign looking respiratory epithelium or pneumocytes, when the imaging studies reveal a definitive mass or abnormality. There was a lot of controversy in this by the committee that set up this particular category, and they could not come to a real firm agreement. So they decided that specimens that have normal elements but a non-matching X-ray, such as it shows a definitive mass, those specimens can be assigned to the non-diagnostic or the benign categories at the discretion of the cytopathologist. The caveat is, for that institution or that cytopathologist's work, the clinicians must be informed that that's the rule that we're using. We either assign these types of specimens to the benign category or the non-diagnostic category, and we do that consistently. Next slide, please. This is an example of one lesion that I would put in the non-diagnostic category. There's a group of cells here that have a lot of fibrin or something. They're bound together tightly, and I cannot really analyze what the nuclear features are. So to me, this is non-diagnostic. Next slide, please. Now, the risk of malignancy for a non-diagnostic specimen is about 40% when you're looking at FNA. So it's actually quite a high risk of malignancy because in many cases, you've actually not sampled the lesion in question. So many of them are unsampled or poorly sampled malignancies, hence the high malignancy risk. Next slide, please. Now, report format. It's very important to have a consistent report format. That's one of the strengths of the WHO system. And generally, you make a statement about the adequacy of the specimen. Is it adequate for evaluation? Do you have some material on that slide? And you can say adequate for evaluation. That means in the United States, you can bill for that specimen. The next part is to put it into one of the defined categories, non-diagnostic. And then usually you should put a reason that you've assigned it to that category. Evaluation is limited by preparation artifact. The tissue is entrapped in blood clot, etc. Or another one, non-diagnostic. There's limited cellularity. That's why it's non-diagnostic. And all the cells we see are ciliated columnar respiratory epithelium in the presence of a well-defined mass. This cytologist decided that we will put those sorts of smears in the non-diagnostic category. Others would put them in the benign category, as we'll see. Next slide, please. Moving on to the benign category, one of the two largest categories. In this case, the specimen contains adequate cellular or extracellular material to define a lesion identified on imaging studies. The samples that are composed only of normal epithelial elements may be considered benign when there's only vague imaging abnormalities like a little ground glass and such. So that's one group that goes into benign. But more importantly, you can have samples composed only of normal cellular elements in the presence of a well-defined nodule. These also, as described before, may be assigned to the non-diagnostic or benign categories at the discretion of the cytopathologist, making sure that the clinician understands what you're doing consistently. Next slide, please. Now, diagnoses in the benign category are shown here. It's really a broad category, as you'd expect. Benign respiratory epithelium, pneumocytes or macrophages, in the absence of a well-defined lesion on imaging definitely goes into the benign category. Acute inflammation, large numbers of neutrophils, that can be seen in pneumonias and abscesses in my experience, because we usually go after well-defined nodules. They are mostly abscesses or pneumocytomas. Usually when I see abscess-like material on rows, I will submit material for culture just to sort of backstop me. Granulomatous inflammation, another reasonably common entity in the benign category. Clearly, they can be non-caseating granulomas or caseating granulomas. In my experience, the most common cause of a non-caseating granuloma is sarcoid, although this difference is seen in worldwide distribution. You can get some non-caseating granulomas associated with pneumoconioses and some associated with fungal infection. When you see granulomatous inflammation with necrosis, of course, you have to consider on a worldwide basis that this is tuberculosis. If I see that sort of picture, granulomas change with necrosis at the time of rows, I will definitely send it for culture. Pulmonary infarction can also be recognized because of necrotic debris and sort of ghosts of pulmonary tissue. Nodular amyloidosis, one of those interesting lesions. It can show up as a very distinct nodule on imaging. When you aspirate these FNA, you will get, particularly in H&E stain material, but also in Papa-Nicolau stain material, you'll get a very hyaline material, acellular, and when you see that, yeah, you can go ahead and, of course, get amyloid stains, either crystal violet or Congo red, and those work nicely, particularly on cell blocks. Viral pneumonias, a fairly characteristic appearance. Lots of times you'll find a significant lymphoid infiltrate, but very helpfully, many of the viral infections will have characteristic either intranuclear or cytoplasmic inclusions that will give you a very high accuracy in suggesting the type of virus present. Benign neoplasms, less common than the others, but certainly occur in the lung. These include pulmonary hamartoma, sclerosing pneumocytoma, granular cell tumor, and yes, squamous papilloma. Next slide, please. Now, remember we talked about having absolutely normal elements and still being able to assign it to the benign category. This was an aspirate that obtained only normal pneumocytes that we see here. It went into the benign category because that was the practice of the cytopathology laboratory where this aspirate was evaluated. But what we see is a sheet pretty much near a honeycomb sheet. The cells, not too much nuclear overlapping. The nuclei have nice smooth nuclear membranes, maybe a little bit of nucleolus present in some of them, nice even chromatin pattern, clearly benign, but goes into the benign category in this case. Next slide, please. Now, a difficult one is what do we do with reactive atypia? Yes, this smear contains a number of cells that have enlarged nuclei, somewhat irregular appearance. But two things are a clue that this may be entirely benign. One is there's some inflammation in the background. And the second one is one of the cells almost in the middle of the smear shows a columnar shape. And it has a nice cilial end plate and cilia. And its basally situated nuclei looks identical to many of the other nuclei seen. We know that the ciliated cell is completely benign, so all the others are benign. And this is an example of reactive atypia that goes into the benign category. And you can put that and note that this is categorized as benign in a note that it is indeed a reactive change. Next slide, please. Granuloma, we've already talked about this a little bit. These are nice, very firm, non-caseating granuloma. They're very solid sphere-like structures. They have a little exfoliation of cells off to the edge, which have sort of a spindly or elongated appearance. There's no evidence of necrosis. So this is non-caseating granuloma. In my practice, these are most commonly seen in patients with sarcoid, but I have seen similar granuloma in patients with a fungal infection. If there was necrosis in and around it, then you'd have to think of caseating granuloma, of course, and TB. Next slide, please. What's helpful to be sure that you're dealing with granuloma is you can see little fragments of the granuloma that aren't quite as cell-packed. And we can see that the epithelioid histiocytes, they're somewhat elongated cells. They have moderate amounts of cytoplasm, and the nuclei may be slightly bent, as we see here. So this is a nice photomicrograph of epithelioid histiocytes. Next slide, please. Now let's look at the neoplasms that fall into the benign category. There are not many of them, but they certainly do occur, and they certainly undergo aspiration. Pulmonary hamartoma, squamous papilloma, granular cell tumor, hemangioma, and sclerosing pneumocytoma. Most of these have very characteristic cytologic features. Next slide, please. Pulmonary hamartomas, what you usually see is a fairly large amount of fibrillary or myxoid stroma that has entrapped some bland spindle cells. You may get fragments of hyaline cartilage or adipose tissue, and the presence of adipose tissue really cinches the diagnosis of pulmonary hamartoma. But you also importantly get sheets of bland bronchiolar epithelium or pneumocytes, often to the edge, and that's really another diagnostic clue that you're dealing with a pulmonary hamartoma rather than a chondroma. The bronchiolar epithelium or pneumocyte epithelium may have internuclear cytoplasmic inclusions, another helpful feature, but the intranuclear cytoplasmic pseudo-inclusions are seen in reactive pneumocytes, etc. So they're not diagnostic in and of themselves. Next slide, please. This is a picture of a pulmonary hamartoma. We can see abundant myxoid chondroid sort of material with entrapped spindle cells. Next slide, please. The real clue is shown here, is right next to and partially embedded in that myxoid material are these clusters of epithelial cells. When you see them this tightly together, it's really diagnostic of a pulmonary hamartoma. Next slide, please. Now, sclerosing pneumocytoma, this is, in my opinion, more difficult to diagnose specifically, but there are some clues that I have found extremely helpful. One is these need to be separated from just reactive change, but more importantly, separated from well-differentiated lipidic pattern type adenocarcinomas. And there are some features that are quite helpful. What you see in the sclerosing pneumocytoma are bland pneumocytes and a smaller population of spindle cells, and those spindle cells are important. The cells form sheets and papillae, and you need to look at the papillae because that's where the diagnostic clues will be. Some of the pneumocytes may be enlarged and atypical, and that's where you get into problems with the well-differentiated lipidic pattern adenocarcinomas. Both can have internuclear cytoplasmic pseudoinclusions, but the key is the stromal elements that occur in the cores of tissues surrounded by pneumocytes. Next slide, please. Sclerosing pneumocytoma, very characteristic. The picture on the far right as you view it is a group of pneumocytes. They are fairly uniform in appearance. The nuclei are slightly enlarged, but not very enlarged. They have smooth nuclear membranes. There's a little overlap, but not much. And indeed, these are all benign and characteristic, but by themselves not pathognomonic of the sclerosing pneumocytoma. What is more helpful is the photomicrograph in the center, where we're getting a papillary sort of fragment. And importantly, we see the pneumocytes are lining up along the central fibrovascular core. And even more importantly, when you look carefully at that central fibrovascular core, you will find spindle cells. So spindle cells associated with papillary fragments is very strong evidence that you're dealing with a sclerosing pneumocytoma. And based on these three photomicrographs, I would definitively make a diagnosis, a categorization of benign, and then a subcategory sclerosing pneumocytoma. Next slide, please. All right. Well, what's the risk of malignancy of the benign category? That's very important. That's really what the clinician needs to know, and is also helpful for the patient to sort of get their mind around where they are. As I said before, the risk of malignancy is dependent on sampling technique, and therefore it varies from 24 to 43%. But if we take fine needle aspiration as the technique, most times the risk of malignancy is somewhere around 24%. It's not zero, but it is low. Next slide, please. All right, moving on to the atypical category. Two types of specimens fall into the atypical category. The first is the one that's fairly most directly easily understood. The category is composed of specimens displaying cytomorphologic aberrations or abnormalities greater than those clearly secondary to inflammation or repair, but insufficient for assignment to the suspicious for malignancy category. So it's a intermediate category that helps us break up that spectrum of change into clinically useful groups. The second category, or the second type of specimen that ends up in the atypical group, are lesions that have many but an insufficient number of features of a benign neoplasm. If you see many of the features that you consider this being a benign neoplasm, but you're not 100% sure because you're missing some of the features, put it in the atypical category. Next slide, please. Okay, definition. This is the one that's used by the WHO. The specimen has architectural or cellular abnormal features greater than those seen in benign or reactive lesions, but less than that necessary for assignment to the suspicious for malignancy category. So this is one of the two categories that allows us to keep a very high negative predictive value for a benign diagnosis and a very high positive predictive value for a malignant diagnosis. And atypical as a category is on the lower end of that spectrum. Next slide, please. What are the cytologic criteria? And these are soft criteria. They're qualitative, they're not quantitative. You can have minor loss of honeycomb pattern with mild degrees of nuclear crowding and overlap. It's mild. You can have mild anisonucleosis. The nuclei can vary in size, maybe at most twofold. You can get mild nuclear membrane irregularities, but they're not the rat bite type, very sharp irregularities of the nuclear membrane that you see in a malignancy. There's mild increases in the NC ratio, but usually the nuclear cytoplasmic ratio is still low. And then finally, occasionally, particularly in some cases that are really reactive in nature, then you will get prominent nucleoli. Next slide, please. This is an example of what I would put into the atypical category. In the upper left hand of the slide, there's a group of 5 cells that is benign. If there was just those cells, I'd assign to the benign category. They have cilial emplates, so they're clearly benign. The other cells, the nuclei are clearly enlarged. They're probably at least twice the size of the 9-cell group. There's some overlap, but the nuclear membranes pretty much remain smooth. There's not a huge amount of variability in size and shape in these cells. Yes, there is some overlap, but all the changes are pretty mild. The NC ratio is not abnormally increased. So I would put this in the atypical category. Next slide, please. Example report. We have plenty of material, so it's satisfactory for evaluation. Category is atypical. Then I write a reason generally why I put it in the category atypical. I try and keep that as short as possible, but we can say there's clusters of epithelial cells are present with moderate degrees of nuclear enlargement, nuclear crowding, and hyperchromasia. This degree of atypia is of some concern that it may be very well differentiated malignancy, but it's not enough to place it in the suspicious for malignancy category. Next slide, please. All right, the use of the atypical category should be limited. We don't want to have it as sort of a trash can, a place where whenever we have any insecurity about our diagnosis, we call it atypical. The reproducibility of the category is poor. There's much overlap with the suspicious category, and the malignancy risk is about 54%. Remember, that's about double the malignancy risk of the benign category. So we're actually doing something right as a cytology community, in that we're moving from benign, about 24% malignancy risk, to atypical, 54%, up to, as we'll see, suspicious for malignancy. That's about 80% risk of malignancy. Next slide, please. All right, example report again. Satisfactory for evaluation, atypical, and then an explanation as to why I put this particular smear into the atypical category. Next slide, please. Moving on to the suspicious for malignancy category. This is the second of those intermediate categories that helps keep the positive predictive value of a malignant diagnosis very high, and the negative predictive value of benign diagnosis high. Definitionally, the specimens demonstrate some but insufficiently developed characteristics of a primary lung cancer, metastasis, or lymphoma, while the attributes of the cellular sample raise a strong suspicion for malignancy. They are either qualitatively and or quantitatively insufficient for a frank diagnosis based on purely cytomorphology. And that's important to realize that these samples either don't have the abnormalities, which we'll list in a moment, expressed to a high enough degree, or they're not expressed in enough cells for a definitive diagnosis of malignancy. So they're suspicious for malignancy. Next slide, please. All right. Suspicious for malignancy is a bridging diagnostic category, which includes what some pathologists would consider atypical and others would interpret as positive for malignancy. Inter-observer variability is quite high, as this would indicate, but we use the category to be sure when we call something malignant, it is malignant. And it saves us from having therapy undertaken, particularly surgery, when there might be a benign lesion present. Next slide, please. Now, how do we assign things, or why do we assign things to the suspicious for malignancy category? It can be due to scant material, and this can be due to the nature of the neoplasm. There's some carcinomas that are very scarce. The cells just don't come out, and we don't get many cells for evaluation. Hence, it ends up suspicious rather than diagnostic malignancy. Location of the nodule. There's some areas in the lung that the endoscopist or the radiologist cannot get to. Experienced radiologists and pathologists or pneumologists, we all know that we have colleagues in radiology or endobronchial biopsy people that have various degrees of skill. And, there's radiologists that invariably hit the lesion, sample it properly, and they essentially always get you adequate material. And there's some that struggle. And you need to understand that that can be a problem and lead to less than a definitive diagnosis. Then there's always size of nodule. It's important to remember very small nodules can be hard to hit. Very small nodules, often like all cancers, have a rim of reactive tissue around it. You can sample that, barely hit the actual center of the nodule and get mostly the reactive change with maybe one or two malignant cells, not enough to make a definitive diagnosis. Low nuclear grade is a problem. This is particularly true for things like dividing up sclerosing pneumocytoma from well-differentiated lipidic pattern adenocarcinomas. They can overlap, and hence you're not sure which it is. They can go into suspicious for malignancy category. Sometimes you'll have a low number of malignant cells, sorry for the typos, that are admixed with a large number of benign reactive cells. That's particularly common in small nodules where you get this mix. And it's very, very difficult when there's 2 or 3 malignant cells mixed in with hundreds of reactive cells to be sure it's malignant and therefore put it in the suspicious category. You can have a low number of malignant cells in very heavy background inflammation. This often occurs in squamous cell carcinomas. Again, if you don't have enough clearly malignant cells because they're sort of diluted out by the background inflammation, put it in the suspicious category. And then finally, chemotherapy and radiation therapy changes can be real traps. These cells can that are associated with radiation therapy can look incredibly atypical. They can overlap the morphology of clear-cut cancers. When you have a history of either chemotherapy or radiation therapy, be careful, and sometimes the wisest course is to put them in the suspicious category. Next slide, please. Now, low nuclear grade, as I said, can be seen in some cancers, and that can overlap the atypia seen in benign neoplasms, sclerosing pneumocytoma versus low-grade lipidic pattern adenocarcinoma is very characteristic of this low-grade problem. Put them in suspicious for malignancy. Next slide. This is an example of what I put in the suspicious for malignancy category. We've got a lot of necrosis, dirty material in the background, some inflammation. And then we have this group of cells. And this group of cells has many of the features of a carcinoma, but they're not quite developed enough in that background of inflammation. I am particularly careful not to overdiagnose it as carcinoma. It doesn't quite have all the features. The variability of cell size, nuclear size, is not quite as much as I'd expect. The nuclei, while having irregular nuclear membranes, they're not quite as well developed as I'd like. There's perhaps some nuclear molding, but not quite as much as I'd like to see. So to keep that high positive predictive value of the malignant categorization, I put this in the suspicious for malignancy category. Next slide, please. This is another one. This actually came from a cavitary lesion in the upper right lobe of the lung. And this raises a lot of problems. There's a lot of inflammation here, both acute and some chronic. The cells are very, very atypical. It would seem like it should be a slam dunk for calling it malignant, but there are some problems in that even though there's a lot of variability in nuclear size and shape, many of the cells don't quite have enough nuclear membrane irregularities. This looks like it's vacuolated, so it's probably an adenocarcinoma, but because this was from what was clinically thought to be a fungal abscess, I backed off some and put it in the suspicious for malignancy category. Next slide, please. This is a similar example. This was a bronchial brushing that came from a really flat lesion, but a thickened lesion in one of the bronchi. It was brushed, it produced this material. And indeed, this is clearly squamous. There is variability in nuclear size and shape, but none of the cells quite have the degree of irregular nuclear membranes, irregular chromatin patterns that make me comfortable in putting this into a definitively malignant group. So it went to suspicious for malignancy. They did biopsies at the same time, and what was found was sort of a moderate degree of dysplasia, and a squamous cell carcinoma was never proven. Hence, a suspicious for malignancy was a good choice. Next slide, please. Again, this is another example of one where we have right at the top a columnar cell with cilia. So that's clearly benign. And then we have another group of cells just to the left and below that that also have a cilial end plate. And we can see the nuclei are enlarged, but they have more of a reactive appearance than anything else. The nuclear membranes are smooth. They're not varying much in size or shape. So I think all of that is actually benign. But then we have the problematic cell. It's a very enlarged nucleus. It has a big nucleolus, and yet it doesn't have nuclear membrane irregularities, and we can't tell how it interacted with other cells in the cell group that this came from. So I put this in to the suspicious for malignancy category based on the fact just one really atypical cell, which does not have all the criteria of malignancy. Next slide, please. And then another example, clearly squamous epithelium, loss of inflammation in the background, though. There's 3 or 4 atypical cells that have abnormal chromatin pattern, but they're still reasonably smooth nuclear membranes. And we have this inflammation. It came from a cavitary lesion, and this was in fact all reactive squamous metaplasia lining a mycetoma. Next slide, please. Just showing you, here's an example like that where we have just one cell. In many respects, it has most of the features of malignancy, except it's a single cell in a background of many cells and inflammation. The nuclear membrane is still rather smooth. So based on this, I cannot make a definitive diagnosis of malignancy, even though I'm very suspicious for malignancy, goes in the suspicious for malignancy category. Next slide, please. Okay, example report. All of those were satisfactory for evaluation. There was enough cells. I put them in the suspicious for malignancy category. Then I explained why I did that for that last lesion. It was a cavitary lesion. There were some atypical cells. I thought that they were possibly malignant, but with the background, I could not definitively call them malignant. It went in the suspicious for malignancy category. Next slide, please. Finally, the category malignant. This is the one we want to be sure that has a very high positive predictive value for malignancy. And everything we've done before is aimed to keep the malignant category as pure as possible. Definitionally, specimens will manifest unequivocal malignant cytologic diagnoses. Cytologic attributes of either a primary or metastatic neoplasm. So we are sure we have all the features necessary for a malignant diagnosis, both qualitatively and quantitatively. Next slide, please. Now, in some cell centers, most of the common cancers sampled are metastases, and therefore we have some of the issues of defining where that metastasis comes from. Immunohistochemistry is very helpful, but in other centers, primary tumors are most often biopsied, and then we have to answer a number of questions. Now, in the past, when you were dealing with what you thought was a primary pulmonary malignancy, all you had to do was distinguish small cell carcinoma from non-small cell carcinoma. And that was, in the vast majority of cases, pretty easy. But life has gotten more difficult. And today, in the vast majority of cases, this isn't acceptable. Those non-small cell cancers have to be successfully divided into adenocarcinomas and squamous cell carcinomas because therapy is different. Next slide, please. Now, issues in categorization of malignant diagnoses. Is it primary or is it metastatic? That can at times be very difficult. Sometimes an adenocarcinoma looks like any other adenocarcinoma. Here, immunocytochemistry can be very helpful, as we'll discuss in a bit. The next step is small cell versus non-small cell. We've gotten pretty darn good at that, 90–95% accuracy in most series. The problem is separating adenocarcinoma versus squamous cell carcinoma, and that turns out to be, in many of the more recent publications, difficult. Next slide, please. Okay, distinguishing lung cancer among cell types in cytologic preparations, differentiation from small cell from non-small cell. We do it successfully in over 95% of cases. Now, due to differences in therapeutic management and response, as well as toxicity, it's critical to separate non-small cell carcinomas into adenocarcinomas or squamous cell carcinomas. And the older literature showed that we did that in a pretty highly accurate way, but more recent data doesn't look like we're quite that good. So that distinguishing, if you use cytology alone, no immuno, you achieve it in somewhere between 60 and 95% of cases. It's important to remember that immunocytochemistry, particularly when performed on cell block, is of great value in that separation. Next slide, please. Now, what are the common attributes of adenocarcinoma? Well, you see single cells, and more often you'll find flat or three-dimensional aggregates. And so those three-dimensional aggregates of cells I find most helpful for recognizing adenocarcinoma. The 3D aggregates can include spheres, papillae, etc. The flat sheets that can be sometimes present, you may be lucky and see true acinar structures or glands, although not often. You have to be aware that some squamous cell carcinomas will have necrosis in them, and that can resemble glands. Now, the cytoplasm of adenocarcinomas is delicate, granular. It may be finely vacuolated or large vacuoles. Again, trap is that some squamous cell carcinomas can have degenerative vacuoles. So just seeing vacuoles does not clinch it as an adenocarcinoma. And then finally, the nuclei may be of help. The nuclei in adenocarcinomas are solitary. They tend to be eccentrically situated towards the base of the cell. Going to have slight irregularities of nuclear membranes. They're not massive irregularities. The chromatin is generally finely granular, and often you have very well-developed nuclei, even in low-grade lesions. Next slide, please. All right, this is what, in my mind, is a classic adenocarcinoma. You can see a large three-dimensional group of cells. It looks like it's making almost papillary-like structures, others nice cell balls. We can see the cells exfoliating out, do not show a tremendous amount of anisonucleosis, and most of the nuclei are polarized towards one end of the cell, another feature favoring adenocarcinoma. Next slide, please. However, life is not always easy. This is a little more difficult. It does have considerable overlap. The cytoplasm is modest in amount. There may be in the center some structures that look almost like mucin. The nuclei are enlarged, but they're pretty uniformly enlarged. There's maybe just a twofold variability, not 6- or 7-fold. and we have very prominent nucleoli, all that supports a diagnosis of adenocarcinoma. Next slide, please. Now, the attributes of squamous cell carcinoma. Generally, you have more single cells and flat sheets of cells with very well-defined cell membranes. The cytoplasm can have a wide variety of shapes. They're much more irregular in shape than adenocarcinomas are. You can have polygonal cells, oval cells, strap cells, spindle cells, and when you're lucky, you will see definitive keratinization. The nuclei also are more irregular in shape and size than you see in adenocarcinomas. Instead of being peripherally located in the cell, they tend to be more centrally localized, but that's not always true. The chromatin tends to be a bit coarse. There may be pycnotic nuclei, and in high-grade squamous cell carcinomas, you may get nucleoli, which complicates the interpretation. Very importantly, squamous cell carcinomas often have a lot of necrotic debris in the background. Next slide, please. Perfect. This is a classic example, the poster child for a well to moderately differentiated squamous cell carcinoma. First, a lot of the cells are lying singly. Yes, there's some in cluster, but most of them are lying singly or in small groups. There's necrotic, dirty background. The cells have quite variable shapes. There's some that are clearly spindle shaped. There's others that are polygonal or triangular shapes. So there's a lot of variability in cell size and shape, nuclear size and shape. Next slide, please. It gets more difficult as the degree of differentiation decreases. This would be more poorly differentiated. Here we're starting to see nucleoli, and these cells have a higher NC ratio. The cell sort of in the middle top of the central group probably has some attempts at keratinization that may be helpful, but it's not that nice orangiophilia. So I would be suspicious that this is a squamous carcinoma, but I would get immunocytochemical markers. Next slide, please. For the moment, let's move on. We'll return to how good we are at separating adenocarcinoma and squamous cell carcinoma in a little bit later. The next group is neuroendocrine neoplasms. I think these are now characterized whether it's carcinoid or atypical carcinoid in the malignant group. Histologic classification of these neuroendocrine neoplasms is based on cell size, mitotic figure counts, and the presence and amount of necrosis. That's true for both carcinoids, atypical carcinoids, and large cell and small cell neuroendocrine carcinomas. These cases do create challenges for cytologic diagnosis. It's very difficult to distinguish, as we'll see later, typical from atypical carcinoids, as mitotic counts are really not usable in cytology materials because the density of the cells varies, so you can't do it on 2 millimeter square sort of evaluations. And it's hard to see the presence of small amounts of necrosis that may help in defining an atypical carcinoid tumor. So I don't even try in separating typical from atypical carcinoid tumors. I just put them into the neuroendocrine group that's not small cell or large cell neuroendocrine carcinoma. It may at times be difficult to distinguish small cell carcinomas and large cell neuroendocrine carcinomas from some of the other non-small cell carcinomas. The lower grade neuroendocrine neoplasms are generally graded into 2 cytologic grades, but I indicate that is difficult to do, and we'll talk about it a little bit more later. Next slide, please. Now, let's look at what we generally have a lot of success at diagnosing small cell neuroendocrine carcinoma. These yield very highly cellular smears that are made up of single cells and aggregates. There's a lot of molding, rosette formation, uniform small cells, and inconspicuous nuclei. The background often has a lot of necrosis, and you may see blue bodies on dip-quick material. Next slide, please. This is classic appearance of a small cell neuroendocrine carcinoma. Lots of nuclear molding, lots of nuclear overlap, essentially no cytoplasm here. Next slide, please. Same is true, that salt and pepper sort of chromatin pattern in this Papa-Nicolau stain, classic for small cell neuroendocrine carcinoma. Next slide, please. Now let's look at carcinoid tumors. They can have single cells, aggregates of cells. Some of the aggregates may have palisading, may even have pseudo-rosette-like changes. The cells are generally quite uniform, round, oval, and some of the peripheral carcinoids, they may be spindle cells. The nuclei are round and oval. They have smooth, delicate membranes, finely granular, sort of salt and pepper type chromatin. Cytoplasm is scant to moderate in amount. You don't see molding. The background tends to be clean. Some of the single cells can be plasmacytoid in appearance. Next slide, please. And this is a classic example of a grade 1 carcinoid tumor. Cells are quite bland. There's no real nuclear molding, salt and pepper chromatin. Next slide, please. At this lower power, we can see that many of the cells have a so-called plasmacytoid appearance, very characteristic of carcinoid tumors. Next slide, please. Now, how well do we do at separating squamous cell carcinoma from adenocarcinoma? 2 of the early studies said we were really good, somewhere around 90% concordance between what cytologists call it and what it turned out to be. There's more recent, larger studies looking at several hundred cases or a couple hundred cases with expert pulmonary cytologists, and the agreement between what it was called and what histology showed was somewhere between 50 and 60%, a little bit more accurate for squamous carcinomas than adenocarcinomas. So unfortunately, we're not particularly good at it. Next slide, please. And hence we want to use immunohistochemistry. I find using TTF1 and P40 is the best because that allows us to save material if it is an adenocarcinoma for molecular analysis. Next slide, please. Metastases, they are common in the lung, and you always have to consider them. About half of pulmonary malignancies actually represent metastases. Immunohistochemistry can be very helpful in identifying the primary site. Next slide, please. Sample reported malignant category, satisfactory evaluation. Category is malignant with a subcategory positive for adenocarcinoma, and then a comment as to why we put it in that category. Next slide, please. Example report again. This is a metastasis, satisfactory for evaluation. The category would be malignant with a statement as positive for metastatic melanoma based on immunohistochemical findings. Next slide, please. Categories do not have definitive cut points. Next slide, please. And indeed, this shows the problem we have. On the far left, we have something that all of us would agree is absolutely benign. Nice columnar cells, cilial end plates. And then on the right side, I think all of us would agree that this is a malignancy. Very atypical cells, nuclear crowding, nuclear molding, nuclear overlap. But the tiles in between show the cytomorphologic range. We can see the one nearest right from the left has many of the features of a low-grade lesion. There's not much elevation in NC ratio. There's some crowding, but not much. So that would go in the atypical category. The next one over towards the right, these cells have many of the features, but not all of the features of a malignancy. And therefore, because they just don't quite make it, it goes into suspicious for malignancy diagnosis category. Next slide. Just to show some of these, you can see on the left side, something I would call atypical. Not a lot of nuclear membrane irregularities. NC ratio is pretty close to normal, whereas on the right side, we have something that has all the features of an adenocarcinoma, loss of nuclear overlap, irregular chromatin pattern, irregular nuclear membrane. So that is one of the issues that you have to divide up by using those intermediate categories. Next slide, please. Now, separation of categories depends on both the degree of a criterion's expression in individual cells as well as the number of percentage of cells that express those features. Next slide, please. The categories divide that spectrum I've shown you of morphologic features into clinically useful categories, but obvious breakpoints don't exist. It's a qualitative exercise. Next slide, please. And this qualitative nature of criteria results in reduced inter-observer agreement and difficulty in specimen assignment in some categories. Next slide, please. Reproducibility of WHO categories is only fair. It has a kappa of 20. It's not really great. And the areas of problems are separating negative from the suspicious for malignancy. That was the problem in 10% of cases in this series. Atypical versus suspicious for malignancy was the problem in 21%. Overall, about 10% of cases will have crossover among observers between the atypical and suspicious categories. Next slide, please. Is the atypical category necessary? I think so, because it does have added value in helping stratify the risk of malignancy. And we seem to be pretty good at that because atypical has a malignancy risk of 54%, whereas a suspicious for malignancy, the malignancy risk is 84%. Next slide, please. Atypical category is a mixture of reactive changes, low-grade malignancies, and some of the problems are sampling issues. Did we get an adequate sample or not? Next slide, please. The peripheral zone can be a problem. We've discussed this before. When you aspirate a small lesion, most of your material may be from the peripheral zone. It's just reactive change with only a few malignant cells in it. Next slide, please. And that ends my talk. Thank you for your attention, and we'll open it up at this time, I believe, to questions.
Thank you so much, Dr. Layfield. That was an excellent overview. I'm not observing any anything in the Q&A box at the moment. I do have one question. We always will be posed with the scenario from time to time of the poorly differentiated tumor. But for those settings in which there's limited access to immunohistochemistry, what kind of recommendation for terminology and reporting with this system would you propose?
Well, that's one of the strengths of this categorization scheme. Generally, there is an X-ray available. It may just be a plain chest X-ray, but you know, radiologists actually are amazing people, and they can tell us a lot about the characteristics of that lesion. And clinical history is exceedingly important, and that good clinicians exist everywhere in the world. And they can tell us a lot about whether it's probably a metastasis or it's a primary. When I was at Duke, I was always surprised that one of the older surgeons, he would come up with his specimen, which was great, and he'd plunk it down, never had had a biopsy, and he would say, this is a squamous cell carcinoma. And he was right 90% of the time that it was squamous and not an adeno. So I think the categorization system that we have, where we can get it into the malignant category, and we're sure it's a malignancy, that is a huge amount of help to clinicians. And then they, based on their radiographic findings, based on their clinical histories, often can get it to the point whether it's a metastasis or a primary. And once you've done that, you've done 90% of the work. You know, the definitively getting it into an adenocarcinoma versus squamous in the very, very poorly differentiated lesions is probably less important than you choose to believe.
Yes, thank you very much. I know that there's some terminology, for example, if it's clearly an isolated lung lesion, for example, and has malignant characteristics, and then the breakdown is it small cell versus non-small cell, obviously, and then if the comfort is high that morphologically this is non-small cell, then one can say, if there's more squamous differentiation, then favor poorly differentiated squamous cell carcinoma versus poorly
Correct.
differentiated adenoma,
Absolutely.
or not, or frankly can't tell, but just wanting to know if that would still, it sounds like it would still fit well in this new system.
Oh, it does. It would fit very well because it's a malignancy. And usually even the poorly differentiated ones, you can get small cell, non-small cell. And, that's a good chunk of it. When we have very expensive chemotherapy and such available, going the next step is important. But if the patient is undergoing, surgical resection or radiation, probably not so important.
Okay, well, thank you very much, Dr. Layfield. That was an excellent overview, and we look forward to when it will be released. And I see no additional comments or questions, so we will go ahead and conclude. Thanks to the participants for attending, to Dr. Layfield, obviously to you for giving us this excellent presentation. And we will see everyone next time at the next session. Thank you very much, everyone. Take care and goodbye.
Thank you very much.